Okay.
I do well in the choir.
Okay.
Are you?
So now you're going to be good. Once it goes, stay there for Where's Jim?
I know I'm so good. I'll text. Yeah. Fun stuff happening this morning. Cool. She's on her way. She's almost here. It's okay.
What's a slip? That's why we need it.
Yeah.
Yeah.
I'm using my own pen. I'm using my own pen. I don't want I'm hoping it's just strain it. I'm hoping it's just allergies, but
Everyone, very quickly, I would just like to introduce Daryl Mishis. He is IT support here in the Albuquerque metro area, and he will be running the show today from the PowerPoint side of things. So normally you all look to me to advance the slides. Today you'll be looking to Daryl. We've rehearsed, but please be patient with him since it will be his first official time running the show.
Could you also let them know the easiest way to access the internet? Do you have Wi-Fi?
Yeah. There's the official way to access the Wi-Fi here in this building is to go to the NMDOH account that shows up on your phone or your computer, and then you'll enter the password HEALTHYNM, all lowercase. So the word healthy and then NM. Then you'll open up a web browser like Internet Explorer, and then you'll put in your first name, last name, and your computer credentials, your computer password. That's the sort of the newer way that we're accessing the Wi-Fi at our locations for security purposes. If you do have any problems, please let me know. Thank you. Chair over here.
Why am traded?
There may be a
Just pause it.
Or just
you might have to just manually use this way.
Hey, good morning, everyone. We'll go ahead and get started. We had a few things happening that we had to address. If we could just go around the table and Jill, just getting situated, but if we could just start and we can do our introductions.
I'm Jill Marshall, Administrator of the Sonas Community Program.
I'm Bill Sheltry, Chief Nurse.
Francis Tweed, NMDOH Administrator.
Michelle Fields.
Jeff Esquivel, ALTSD.
Dave Collins, NMDOH Clinical Director.
I'm Shalissa Lee, Assistant Secretary.
Roy McConnell, ASD Director for NMDOH.
Lynn Gallagher, Department of Health.
Gabrielle Sanchez Sandoval, Department of Health.
Carmela Sacklog, CTC Administrator.
Hospital Administrator for New Mexico Rehab Center.
Hartley, Troopers Lodge Hospital Administrator.
Todd Winder, Administrator, Fort Bragg Medical Center.
Berta Hill, Department of Health.
Matthew Eastwood, ITSD.
Daryl Mishis, ITSD.
Rory Ricker, New Mexico State Veterans Law and Finance Director.
Eric Shea, Legislative Finance Committee.
Casey Tyrone, I'm DFA. Shelley Strong from Health Care.
Sorry, Morgan, Department of Health.
Has everyone had an opportunity to look at the agenda? And if so, there's no amendments, if I could get a motion for approval of the agenda. Have a second?
Second.
Has everyone had an opportunity to look at the minutes from the previous meeting? And if so, if I could get a motion for approval of those minutes.
Just saw one change that was needed. The ones I read didn't indicate that Fort Bragg did a presentation last time.
Okay. have a motion for approval of the minutes with that amendment to accurately reflect that Fort Fair did in fact give the presentation?
So moved with amendment.
Have a second, please?
Second.
Just welcome everyone to the meeting. I'll turn it over to Gabby quickly, but just want to welcome everyone and welcome to the fiscal year. The facilities, happy fiscal year day. The facilities worked very hard under inordinate circumstances, and I'm very proud of the cutbacks and the sacrifices that we've made. We'll get into each of that later, but I just wanted to acknowledge that. I also want to take a moment and acknowledge the Mexico State Veterans Home and all of their staff and the work group that we created to help make that really seamless, transition. And you're still part of our broader family, and I just want to acknowledge that it has been a lot of coordination and a lot of work from a number of different people, but from the perspective of the outward presentation, it really was flawless, and there really was no bump, there was no weird acknowledgement. And so as we work on this bridge here and the transitions that are going on, those relationships remain pivotal. So I want to give my personal thanks to Colleen and to everyone, Marie, to Janet, everyone at the Veterans Home, all of the IT staff and all of the nursing and medical staff who helped us just do a really great job to keep this level. So thank you.
I just wanted to mention one thing because there seems to have been a little bit of confusion and not a couple of questions from legislators, and then in a different forum, in our Jackson forum, there was a press release that went out about the ability for the Department of Health to hire nurses after they graduate. And unfortunately, people have sort of misunderstood that to think that we're going to be bringing in unlicensed nurses to our facilities. Of course, that is not true. It's actually just a mechanism for us to be able to capitalize through the state system on something that was already allowed through the Board of Nursing Regulations. So if you guys have any questions about that, of course, feel free to ask me, feel free to work with HR. But the bottom line was that the state system required as a minimum requirement to be hired into a basic nursing position that you already have your license. So we had a lot of great relationships with schools in terms of having internships or other relationships with the students that we were not able to then quickly transition the students into a working position because they had to pass and have their licensure before they could even begin employment. The Board of Nursing already allows, through a permit process, for someone to be identified with a specific employer and a specific licensed nurse supervisor to be able to work for up to 6 months. So I just wanted to say it out loud in case anybody here had any questions or concerns about it. We don't want to lower our standards of care by any stretch of the imagination. We just want to be able to support and foster those relationships with students and bring them in and help them realize the great opportunities there are to work for the state of New Mexico in our facilities and our divisions. So just wanted to say that out loud because we've gotten a couple of questions about it. And I also just wanted to mention how grateful I am that we all are working on this backpack challenge to collect backpacks for the foster children in the New Mexico foster care system. And I've been very pleased and, just excited, yeah, exactly, that everyone has really embraced this. I know that we all have our own challenges in our lives, and the work that you guys do already is so giving and so difficult. So it's just really nice to see how everyone's come together on this special acknowledgement to Turquoise Lodge. They're a small organization, but they really stepped up and already collected a lot of backpacks for the foster students. I really appreciate it. And that's on top of their Turquoise Hugs initiative, which they're also doing. So again, thank you to all of you. We really genuinely appreciate the effort that everyone is making to collect those backpacks. So thank you very much. And we'll go ahead and get right into our facility administration report. So we'll start with the state veterans home.
We're gonna talk to this here.
Thank you, though.
Can we just do it from right here? I speak very loud.
No, because he has to
We'd
get.
like to
Okay.
have you on, yeah.
Okay, that's fine. I didn't know there was a count.
Yeah.
Gee, I got all pretty.
Janet, want to come over here?
We're teaming up today.
Yes.
The New Mexico State Veterans Home has.
Yes.
Oh, I'm not under yet.
One moment, we'll bring it up.
Okay.
And now Daryl will advance your slide, so he'll pay attention, but look to him when you're ready for your next slide.
All right. The New Mexico State Veterans Home has worked very hard on increasing our census this year. Our last quarter occupancy was at 89.6%. This last quarter, we advanced to 96.3%, which was an increase of 6.7%. Over FY17, we had 80 admissions and 3 readmissions, and from January to June, we had 60 admissions. And we accredit that all to Karen, who worked diligently at working hard to get all of our admissions in. Currently, the nursing home is completely full. We have a waiting list going on that, and our domiciliary currently is working at filling it. We had our first real admission into domiciliary yesterday, so we increased it to 6. Finances are, oh, go ahead, I'm sorry. I have it on. Our finances for FY17, we projected a $64,000 shortfall. We're hoping to, there was some encumbrances that are not going to be going through, so we're hoping to make that even smaller, which is a big difference from FY16, where we had a $853,000 shortfall. And we're really proud that our contract money was way down this year. Last year we had a 2.2 in contracts for nursing. This year we only spent 1.5, which we're really happy. A lot of that we attribute to the rapid hires that we had through the year that really made it possible to use less contract nursing. So that really made it possible for us to keep a really close eye on our contract money. We did have an increase in our service-connected beds. Last quarter, we had an average of 640 days on contract beds. This last quarter, we had 830. What that means is that at the beginning of the fiscal year, we had 1,800 service-connected veterans in our facility, and by the end of the year, we had 27 service-connected veterans, which means VA paid 100% of their care, which made a big difference in our collections. Our fourth quarter collections and third-party collections was at 115%. We worked very diligently at trying to collect all of our money, which was higher than our year-to-date third-party collections ended up at an average of 108% collection. So we did work really hard at trying to collect everything that we could for the Veterans Center and try to end on a positive note. But just a little shortfall. I'll turn it over to Janet to go into the human resources.
Okay, as you can see, the hires we have, vacancies, and total turnover and nursing turnover rates. And for the quarter, the average turnover rate was down from the previous quarter. We were at 2.3 versus 3.2% last quarter. Our quarterly vacancy rate went up slightly. Disciplinary actions, we had very few disciplinary actions this quarter. And our reportable workers' comp claims, again, we had a few. We'd like to see that at 0, but unfortunately we had 4 in May. 1 of those was denied, however, and 4 in June. One of our recent hires included our safety, risk management safety director, and his name is Steve Cox. He's the previous state fire marshal, so he comes to us with lots of expertise. We're really happy to have him, and he's already shown what an asset he is to our facility. Accomplishments. This quarter, a successful rapid hire. We had a rapid hire the first part of June. We started out with hiring 17 positions, and that was going to fill all of our vacant CNA positions. And by the time it was all over, we lost a few of those, but we did hire 12 positions, so we were in good shape. The rapid hires have been very successful for us, and each rapid hire we have had gets more successful. We have more people that have come, so they have made a tremendous difference for us in Mexico. Also, improved census, as Marie had pointed out too, an improved census for and payer mix. The completion of our annex, the building part, they're still working on the finishing work. We're still getting deliveries in. The deliveries started July 5th, and they keep coming in. We prepared for the fire marshal inspection of the annex, and the transition, as Lynn alluded to in her opening statement, the transition from the governance of Department of Health to the governance of New Mexico Department of Veteran Services. We want to thank everyone who's helped with that. Everybody's been, just team players, and we still have lots of work left to do, and I'm sure it's going to continue for a while, but everybody's been super supportive, and we really appreciate that. Also, in this quarter, they looked at and reduced the amount of documentation for the social work, the clinical documentation, to increase the efficiency and allowing additional time for direct patient care, and that has helped tremendously too, with our growing census and the increased need of the social workers. It's helped a lot. Needs this quarter, we're awaiting the CMS clinical and life safety survey results. We had our survey began on June 26th. It was a good survey. Our administrator is very happy. We'd like to get zero deficiencies, but unfortunately, I think those are kind of a thing of the past. But it was a good survey. Then preparation for our annex, that was a challenge and continues to be a challenge as we get closer to the opening date, and things keep coming in. Finalizing the governance transition from DOH to DVS. As I said, that's an ongoing thing. We still have lots of things to work on. In fact, on the way up here, Marie and I were talking, and the light bulb went off in her head. There's something you forget, and we're sure there's going to be many more of those ahead too. Projects, the implementation of the New Mexico State governance transfer, as that's in the project and continues to go on. To prepare for the annex opening, we've identified 21 veterans that require the memory care unit for the transfer, and then prepare for the decreased revenue, because those 21 residents, veteran residents residing in the non-recognized veterans home, we will have reduced revenue until we get that recognized as state veterans home. Regulatory and accreditation, Centers for Medicare and Medicaid Services. And the immediate jeopardy that we had for our CMS survey last year, the fine has been paid, received and paid. We'll request a CMS life survey for the annex when ready. and then they'll come in. But John Hess from CMS had identified that a standard clinical CMS survey is not necessary because we are not increasing our bed size for license. So it will just be the life safety survey for CMS. CMS life survey was completed for our main building. 5 areas of deficiencies related to paperwork were identified and walked through evidence, no areas of concern. Like I said, our administrator was pleased with our survey. It was mostly paperwork. We can get those corrected. I have a problem. We're waiting for our final results, though, to put in our plan of correction. Annual certification survey began on, like I said previously, June 26th. And the Department of Veterans Affairs will request a VA recognition survey once we get our 21 veterans transition from our main building to the new annex. Customer satisfaction surveys, we've been doing customer satisfaction surveys, and they've been extremely positive and designated best in class in the following areas: overall satisfaction, nursing care, dining room service, quality of food, individual needs, response to problems, recommend to others. And we always like to hear that because that's the best form of advertisement, is recommending us to others. Activities and combined average. So if anybody has any questions for us. Yes. Yes.
I just wanted to know, how long are you guys expecting it to take after you get the 21 veterans in their first certification?
We're hoping to be over there, and this date has changed along the lines, but we're hoping to be in there by September 1st, and then have our grand opening November 11th.
So, and I would say that under the Department of Veteran Services, it's my understanding that they, not dissimilar to what we have under CMS requirements, they have a number of days within which to conduct that survey, but they don't give you a date. They don't say that it'll happen in 5 days, 10 days, 20 days. They have a range, and the survey must be completed within X amount of time. So once the 21 beds are filled, then at that point, the clock ticks, and then between
Whenever they decide they're
30
going
to
to come,
60, 90 days, whatever the VA's administration's requirement is, they'll come in within that time period, but we won't know. But they try to do it expeditiously because they know that until we have that survey, they're sort of limited in reimbursements. Does that make sense?
Are there any other questions for the state veterans? We did talk a little bit before, and I'll talk a little bit about it later, but we're going to, give an invitation to the state veterans home to remain at least an ex officio member of the governing board, for whatever amount of time they'd like, so we can continue that formal communication and continue learning about things that are happening at the other facilities, staying in tune about what's happening there in the event that we can support one another.
I think it's an important connection to continue, just because there are so few state operated, regardless of what branch the agency you're under. I think it's an important connection to keep, because a lot of the referrals can also come as a result of some of these relationships.
Thank you guys. Thank you. Our next presentation will be by the Mexico Behavioral Health Institute, Francis.
Camera.
Okay, good morning. On my first slide, indicate that we have the 5 separate divisions, adult psychiatric division, and we have 96 operational beds. We have 2 admission units and then 4 extended care units. Forensic has 84 operational beds. Our community-based services is our outpatient component. And then we have the care, which is our adolescent program. They have 12 operational beds. And those are adolescents that have exhibited sexually harmful behavior, and we're trying to break that cycle. And then we have our long-term care facility, which is licensed like any other nursing home in the state of New Mexico, and their operational beds are 163. We are fully accredited by Joint Commission. We are surveyed under 3 separate standards when we have our survey. Under hospital standards is adult psych, forensic, and our outpatient component or service are accredited under the hospital standards. Care is accredited under the behavioral standards. And long-term care is accredited under the nursing care center standards. We're expecting our triennial survey is due by November, so we're trying to get ready for that. Licensing, we did have our CARE CYFD certification survey on June 27th through the 29th. We did well. We had minor findings that were related to our initial screening for functional limitations, notification to PCP upon discharge from the program. We always do that. However, periodically we do have some adolescents that have to return back to, they violate their parole, so they return back to whatever program in Albuquerque. So we don't really have a PCP to return to. So we're trying to figure out exactly how we're going to get that done. And then documentation of the guardian after an emergency discharge. Now, the window for long-term care is open, and actually our 15th month is over next week. So we're in hopes that they do come next week, only because if they don't, we probably can expect we will have not just our licensing and certification, but we'll also have CMS accompany them. That happened to us years ago. Where we had like about 8 surveyors, they had the licensing and the CMS surveyors. So fingers crossed, I think we're ready for them, and they'll be here next week. Dr. Dorman did conduct medication management tracer on May 2nd. It gave us a lot of good recommendations. Our average daily census by division for the quarter, adult psych had 79, forensic at 47, care was 9, long-term care was 155, and the facility total was 290. Our outpatient census information, I've broken down how many patients we have. We have a total of 1,032, and I have broken down what different areas in service. We do have clinics, and our main clinic is in Las Vegas, and then we have a clinic in Pecos, Mora, and Santa Rosa. And in regards to our budget, we don't segregate an operating budget for each service line that we provide. Our original operating budget was around 57 million. We had a decrease of 1.6 million from the general fund for this fiscal year, and our total operating budget was 55.5 million. Uncompensated services provided, this did go up from the last quarter. It looks like for this fiscal year, we're projecting that we're delivering 2.3 million per month of uncompensated care, and the primary reasons for that is no funding in forensic, because there is no reimbursement for patients in forensic, 2 indigent residents of long-term care. Average payment for our patients on the adult psychiatric division is only for 3 to 5 days. We have to call in review every day to the MCOs. Of course, we can't necessarily discharge them at the end of that period if we don't have a safe discharge. We did that 59% of our patients that were admitted to the adult psychiatric division this quarter did have billable insurance. But there is no payment for some of our patients because they're coming on 30-day court commitments. So by the time we get them into our facility, the facility they came from has already exhausted all the benefits that their insurance would allow. Contract costs projected for this year was 3.4 million. I broke down the different contracts that we have by program area. For example, we have the pharmacy, nursing services and psych, religion, cost reporting service, transcription, fingerprinting, drug and alcohol, software maintenance. So all those services are included in that projection. Other financial information, our fourth quarter collection rate did go up to 90% from 89%. We do currently have a vacant claims processor position and a budget analyst position that we actually were able to interview this week, so hopefully we'll get those positions filled soon. Best practices, we did decrease our contract amounts this fiscal year. We were able to, thanks to Dr. Collins, our clinical director, we currently don't have any budget commitments, is that correct?
No.
We have been able to go to provider agreements, which has really saved a significant amount of money in those contract category. We get receipts every week. Our providers have to submit a weekly invoice, and that allows us to keep track of exactly where we are. We continue to purchase items for direct patient care only. We do have some level 1-to-1 patients, and we evaluate that on a daily basis to see if there's any way that we can decrease those, because that really increases the overtime. We're continuously reevaluating our staffing levels throughout the entire facility, and our contract for forensic patients with HSD is complete. However, we're having some technical difficulties in submission of data that IT has been working on, so we're hoping that that will get completed soon, and that will allow us to have reimbursement for the hospital if one of our forensic patient gets admitted. Right now, if they get hospitalized, we're having to pay that bill for the hospital. We do have an RN case manager that continues to assist patients within the adult psychiatric division with Medicaid enrollment, and she's been successful in enrolling 9 patients in this past quarter. She has been able to receive some reimbursement for the patients that were admitted, so that has helped with our revenues. Our projects, we do have funded projects for the cottage renovations, roof replacements, campus surveillance, our HVAC replacement for the adult psychiatric division, Meadows 3, Phase 3, food delivery vehicles. And we do have 2 unfunded projects that we're requesting, and that's the asbestos abatement of the ZIA building and then fencing at APD and surrounding buildings to try to prevent elopements. And I think George is going to give us a report later on the ICIP. Human resources, our direct care vacancy rate is still pretty high, 24%. That was the same that it was last quarter. Nursing department currently has a 22% vacancy rate for psych techs. That represents 87 FTE positions. And the rate for nurses is 20%. We did hire a couple nurses so that we have 21.5 vacancies. Beginning of the year, we had 28, so we have successfully hired some nurses. Employee hires by month, we have 4 in April, 16 in May, 30 in June, for a total of 50. Recruitment efforts, we did have a rapid hire recruitment event in June to recruit and hire nurses and techs, and we did successfully hire 20 techs and 2 RNs. We requested for this fiscal year to hold quarterly rapid hire recruitment events, so we're hoping that our next one will be in September. And we did identify a performance improvement team to continue work on recruitment and primarily retention efforts. Our performance measures, we did meet some of them. Our operational beds were at 83%, and of course our vacancy rate for direct care positions is pretty high, and we're at 90% for our third-party revenue collected. Risk management data for this quarter, we had 28 notice of accidents. 12 were reportable, and we only had 7 days of lost days for them. On our patient satisfaction, I did a little breakdown of what some of our areas are saying within the adult psych forensic care. 94% were satisfied with care and services. For that same group, 94% were satisfied with feeling safe. 95% believed that the hospital staff were helpful. And at the outpatient program, 98% were satisfied with the services that were provided. At long-term care, the residents did report 94% that the caregivers are helpful and respectful, and that the nurses took good care of them. That was at 96%. Community connections, I listed all the different things that NMDOH participates in with the community. For example, the New Mexico Coalition of Sexual Assault Programs. We belong to the Guadalupe and the San Miguel Health Council, the Behavioral Health Crisis Task Force for BHSD, the MCO Committee, Las Vegas Community Development Department Housing Advisory Committee, San Miguel County EMS Task Force, the New Mexico Board of Psychologist Examiners, State of New Mexico Pharmacy Representative in NMCAP, and then WIPSHOP. We are members of the Western Psychiatric State Hospital Association. On employee survey and feedback, we did do our culture of safety survey in May. And most of our negative feedback was related to the amount of overtime, which we were expecting. And it's because of our vacancy rate for the techs, there is a lot of overtime. And a team has been identified to work on a formal corrective action plan to address those findings. On training initiatives, we did have employees from Standards Compliance attend the QIPI training workshop in Albuquerque in April. Dr. Russell, who's our APD Division Director, attended crisis communication training in June. We had 2 CVS behavioral health therapists attend the sexual violence prevention learning community meeting in June. And we do have all employees are required to attend an 8-hour mandatory training session that includes all the training requirements for Department of Health licensing and certification. Positive stories. I did want to talk a little bit about what we're doing with our patients and residents. We do have the Santa Fe Mountain Center that works with our care adolescents. They come weekly, or our care adolescents actually go to Santa Fe for different events. They've done rope climbing and they do fishing at the farm. And the focus is really on experiential therapy that promotes teamwork and empathy building. So that's a very successful program. And during this summer, PSR Psychosocial Rehab has been scheduling classes and activities for our care residents. And our PSR employees held classes for all our patients at the Adult Psychiatric Division and Forensic during Mental Health Month. And CPS posted a display with information for our clients. And Psychosocial Rehab offered 2 all-hands activities at the farm in celebration of Cinco de Mayo and for the 4th of July. And we were able to include patients from APD, CBS, and CARE. Our vocational work program currently employs 26 patients or clients from APD, Care Forensic, and the assisted living facility. Handicapped patient-friendly platform is constructed at the farm, the horticulture sign that will allow easier access for our patients. And the farm is producing more vegetables this year, and they're being sold at the Turquoise Cafe, and all the proceeds go back to the farm. And NMDOH did complete, I mentioned the HSD contract that will allow for our forensic patients who are hospitalized to be covered through Medicaid. And then we did enter into a service agreement with Presbyterian to provide physical and occupational therapy, and we are going to hope to expand that to other insurance. I just have a picture of the poster that we did post at our outpatient on the Mental Health Awareness Month. And the other thing that we did is we celebrated Nurses Week in May, CNA Week in June, and we did different things for our techs every day of the week. And then for the nurses, we did give you some gifts. And that is my report. Are there any questions?
I just wanted to know a little more about the contract with HSD on the forensics unit.
Mm-hmm.
What is that? So,
Once the patients come into forensic, they lose any Medicaid coverage or any coverage that they have, we were able to get into an agreement with HSD where if they are hospitalized as an inpatient, they're going to cover the cost for that hospitalization. And then I believe they bill Medicare, so they will reimburse the hospital, and that way we're not having to pay for that directly.
So that would be for all patients?
That's forensic, only if they are hospitalized. Only the forensic patients if they are hospitalized. If we have a patient within the adult psychiatric division or long-term care and they get hospitalized, their insurance is going to cover that. They have Medicaid or private insurance. But at forensic, we've been having to cover, if they go to the hospital, whether it's 1 day or a month, we have to absorb, we have to pay the hospital for those services.
That's always
Because
in
they-
general fund, right?
Right.
Oh, so if they get hospitalized, if they have to go
to an acute care
Emergency
hospital. They have to get hospitalized for pneumonia or whatever that, and we're anticipating that, with our 1.5 population at forensic, we're gonna see a lot more elderly patients, so this contract is really gonna help offset a lot of our costs. So that was something we worked very hard on for a year, and it's almost complete, the contract's complete, but we're just having some IT difficulties, and we anticipate soon that we'll go live with that.
Wayne Lentz from VHSD. I had a call from a relative of a state legislator who had a family member hospitalized to BHI, discharged to a group home, and subsequently was assessed a week later to enter PSR. And then it was a week later before they actually entered the PSR program. And as a result, the person went back to drug use and ended up being readmitted to BHI. So this was an informal call inquiring about could procedures be changed so that while they're still inpatient, having their PSR evaluation done, and then upon release, be able to directly enter the PSR program. And I said I would discuss this with you all and see if there could be a change to accommodate that, which seemed to make sense from my perspective.
We'll definitely look into that. I can have Dr. Russell work on that. I'm assuming you're with a patient on the adult psychiatric division. Okay. So I'd like to talk with you and get more information. Absolutely, we'll work on it.
Thank you.
Are there any other questions for Francis and the behavioral health institute at Las Vegas? Thank you, Francis. Sequoia Allison Treatment Center.
No, you stay right where you are. We'll come to you.
Sequoia is an adolescent residential treatment center serving adolescent males between the ages of 13 and 17 with violence or history of violence or a mental disorder, and is that they are amenable to treatment. Our census for this quarter, our average census, as you will know, is 26, 25, and 25. I want to speak a little bit to this, is that normally our census is 30 plus. However, we took an opportunity, and I'll speak more into it later in my presentation, but we took an opportunity, I think, to finish or complete our lodge remodel project. We started this project about 2 years ago, and we were doing it, or we're doing the project in-house with our in-house maintenance department, trying to do some savings of costs and not contracting this remodel. Those of you that have visited Sequoia, you would have noted that the lodges it wasn't built for this facility, it was more of a training center. And in each of the lodges, they were built with cinder block. So it gave it like a correctional type setting. So when we started our initiatives about 3 years ago, we wanted to change the environment so it would be more home-like for the residents. And that project, keeping it in-house, we're doing the remodel around the residents. And so we took this opportunity it took longer than we anticipated, and because the boys are violent, we were having to go back and repair and not being able to move forward to our other lodges. So summer is a time period where we get a lower referral rate, so we assess that, and we were able to move all our residents to the 3 lodges and shut down 1 lodge to do the remodel. And we were able to do those last 2 remaining remodels in less than 2 months. So now our whole entire facility has been remodeled, floor is completely done, the walls have been completely done, so we're really excited. So now the next quarter you will see, and all that project was done in-house. And so we saved thousands of dollars on that. that project to do the 4 remodels costed the facility just material-wise about $4,500. Had we contracted out, it would have been plus $20,000. So really excited about that. So you'll see going forward that our goal is to increase our census, and we are currently doing that. All lodges are open, and we will be increasing our census to about 30 plus in the next quarters. We did have this quarter, we had some inspections or audits. We had our fire marshal inspection on 6/21, with majority of the findings being addressed in-house. We also have a biannual kitchen inspection from the health department. This inspection usually is scheduled. This inspection was unannounced. We did very well, minor inspections. I think one of the positives is that we have Global Nutrition Services that surveys our kitchen monthly. So we're always on top of it and always prepared for any audits the biannual audits that we have. So during those surveys, when the Global Nutrition Services, we scored in this quarter 94, 92, 92%. The nutrition service, the Global Nutrition Inspection is very similar to the health department. They look at the same type of items. We also had a quarterly medical records audit, and that was conducted on 5/23 with minor findings, and we're working on those as well. I also want to focus on financial cost containment. I think our secretary has challenged us all to look at that, and yes, it's been a challenge, but it's also opened up ourselves to look at different things that we can do in containing cost. And one of the things that we focused on is the services that are being provided to our facility. One of our struggles, or I think that we find, is that we use the same service year after year after year. And one of the ones that we stayed looking at is the services that are provided for our fire alarm systems. And we were able to relook at other agencies. There's not very many, but we switched over to a different agency and saving the facility over $6,000. The trick in that is that we have to make sure that they're going to inspect the same things the previous company inspected. So for our fire sprinkler, it's a 5-year sprinkler inspection. We saved $6,000 just by switching to a different company. And assuring that they're going to inspect and the fire marshal is going to accept the same type of inspection. So we're really excited about that and really digging deep on what we can reevaluate. And I think it's important that we evaluate our service contracts yearly or every other year to make sure we're not just being repetitive and just obtaining the same one. And are they giving us the best for our money? I did talk about all the 4 lodges. Those are completed. Told you about what we saved on that. We've also improved our collection rate to 92%, and we're daily reviewing. We have a stand-up meeting that we're daily reviewing the daily census, and we adjust for staffing accordingly, and we adjust for acuity and overtime, trying to continually minimize those costs. Our environment and care project. We started the landscaping and irrigation project that was scheduled to start in July, but has been delayed because we're awaiting material delivery. The second part of our roofing project is the gym area. We're in the process of getting bids for that project as well. We staged the roofing projects into 2 stages, completing the ones where we're more emergent, where we're actually leaking, and those are completed and we're awaiting the gym area. Future projects. In 2016, our fire marshal report survey identified that we needed a paved access road in the back where they can access the water hookups for in the event there was a fire. Seeing that was going to be more of a challenge, it's a bigger project. We started to collaboratively work with the fire department, and we started a fire readiness in the event of a fire, have them come and prepare us for that and to determine if they're able to access that back area because it's a dirt road. In that, they were able to identify that their trucks would be able to access those hookups, the water hookups, but also it provided us some other areas that we could improve, so we strengthened our safety plan. And where that helped is that when our fire marshal came back in 2017, they accepted that. So we no longer have to pave that back road, and so we're gonna save money on that. One of the things that they identified was our lodges are named by Jeremiah Bear, each of Milagro, each of the lodges, they came up with their own name for the lodges, more, it's more personal versus Lodge A, Lodge B, which is on the fire plans. However, that's hard for the fire marshal because they don't, when they come in, they come for a fire, they're coming to Lodge A, Lodge B, Lodge C. So we identified that our buildings need to be labeled in according to your fire plan. So that was something that we changed as well and put big letters so that they could identify in the event there was a fire. We are starting to look at the second phase of our electronic access control projects, and those have been submitted, and the HVAC second phase of that as well. Human resources, we do have this quarter, we do have a high vacancy rate where 35 of our vacancies are all in direct care. We are able to have a PRN mental health tech pool where offsets the direct care, the mental health tech. So we do have a good pool of about 12 PRN techs, and our PRN techs stay with us for a long period of time. So it is consistent, and they are considered core staff, and the residents are seeing a familiar face. The reason why a lot of our PRNs pick this track is because they're in school or they have another job, and they're able to control their schedule. And it benefits them, benefits the facility, because we also don't pay for their benefits or overtime. We are still utilizing nursing for nursing contract agency nurses for our nurses, because we do have a high vacancy for our nurses there as well. Performance measure data. Really excited about this. If you noted, I went ahead and put all 4 quarters. We've averaged our duration of we've been tracking amongst other things, but this is the performance measure that I wanted to really point out, is that last year our restraints, which are physical holds, were 280 something. This year our holds were 80 something. So we really decreased that. Our average is 7. Our target was 20. Our average was 20, and we well met that target. Below that target, it's good to be below the 20 target. Some of the things that contributed to the success is we started training on trauma-informed care CPI, trying to focus on de-escalation, always ways on trying to avoid a restraint or a personal hold if needed. Strengthening the staff's de-escalation approaches and techniques. We also have a committee that meets and reviews incidents daily and weekly. And then we also have our 2 API committee that assesses our challenges and our successes for incidents. So. Ask any questions?
Do we have any questions? For Sequoia Adolescent Treatment Center in Carmela.
Who are your psychiatrists?
Dr. Marin, Dr. Sabani, and then we have a prescribing psychologist who is Dr. I'm sorry.
Can you see no further questions? Will you just this slide? My name is Shauna Hartley, and I will be presenting the quarter report for Queens Lodge Hospital. So Turquoise Lodge Hospital continues to provide the 3 service provisions. We have medical detox, which are for patients who are in need of detoxing from drugs or alcohol. Our average length of stay for that program is between 1 to 5 days. We have our social rehab program, which is a 21-day recovery program, which is for individuals who are medically stable and are interested in exploring a recovery path. We continue to provide our collaboration clinic with the county, which is our Moji clinic. It's open every single day, 7:30 to 4:30, or until the last patient is seen. And on average, we see between 15 and 30 patients a day. This is a harm reduction model, so the individuals who are coming through the county, either through emergency services or walk-ins, are not necessarily interested in recovery, but they are interested in stopping their drug use for a period of time. Some of the most significant Q4 service provision highlights is that this last couple of months, we've been in preparation of Joint Commission, and so we've done a rigorous policy and procedure review. We've actually reviewed 92 policies focusing on housekeeping, medical, pharmacy, and nursing, which has been a significant accomplishment for myself and our staff. In being able to roll this out, what we've been doing is every Thursday for an hour, we send the policies that we've reviewed, and then we have all the disciplines come together, and there's an expectation that they've actually read the policies before they come in, and myself and 4 of our leadership members actually allow them to ask questions, or we elaborate on some of the policies that we put out there. So whether you're a housekeeper or you're a care staff or a nurse, we're reviewing 100% policies that we reviewed with all the staff. We anticipate that August 21st, we're going to be opening our intensive outpatient program, and the hours of operation that we are looking at are going to be Monday, Wednesday, Friday, from 9 to 12. Myself and my QI director are in the process of identifying the outlier counties, because we do anticipate providing a transportation piece to this. So we're looking at Bernalillo County, Sandoval County, and Valencia County, and hoping that we are now going to be capturing some folks that want to have IOP as a discharge plan who are coming out of our hospital, and then we're recontacting people that have actually gone through our hospital that either were excluded because they didn't meet the ASAM criteria for inpatient, or they came through our rehab program and wanted outpatient but weren't able to at the time of discharge. This quarter, we've actually completed 100% of our staff competencies, and I'm going to talk a little bit more about that later. And this quarter, we've also provided, I think, a much more quality PDSA process through our quality department. So myself and my QI director did something very different this year. We conducted a force field analysis with an aim statement with different parts of our hospital. So traditionally, that had just included our leadership team, and that hadn't been that successful, because when you just include your leadership team, the changes that you want to make don't really trickle down into your system. So this year, what we did is we included housekeeping, our finance department, all the direct care staff, and so we actually identified 5 PDSAs that are going to include all the divisions of our hospital in hopes of integrating some positive change in a different way. This next slide represents our staff licensed beds. At this time, we have 15 medical detox beds. We have 16 rehab beds, and our occupancy for the hospital is a little bit lower than last quarter. It was 92 last quarter, 88% this quarter, and the decrease in occupancy rate is due to some challenges with losing 2 clinicians. Both of them were actually in the military, and they moved out of country. And we're also anticipating starting our intensive outpatient team, so I have to kind of parlay those clinical resources in preparation of providing a new service line. Our demographics of our hospital continue to be the same. We always service more males and females, and our ethnicity demographics aren't any different from the last quarter. This quarter, what I would say significant differences are is that we are servicing a younger population this quarter. We've been kind of hovering between the 34 and 51 age range for the last 3 quarters, but this quarter we actually had 28% 21 to 30-year-olds. The drugs of choice continue to be the same. It's always more alcohol and secondary opiates with kind of a sprinkle of meds, which is kind of making it come back. Our MOTU data remains the same. We see on average, close to 700 patients who are new. We see about 15 to 30 patients a day. We have 3 different kinds of encounters. We have new admissions. We have individuals who are coming back after they've been seen the first time to ensure the medications that we prescribe are appropriate. And then we are assisting the county now with their medication refills, which has actually decreased their med errors on their end. And if you see the demographics with the drugs of choice, it seems to be the same that come into our hospital. This slide represents basically the data for our hospital in regards to admissions. And as you can see, we have been climbing and climbing and climbing. And this quarter, we actually had the highest number of admissions. We had 178 more admissions than we did last fiscal year. I did talk about this in our last governing board, and this has really contributed to us just making a very diligent effort to look at our access system. So myself, my QI director, and our clinical team, we meet every single month, we look at the data, and we just talk about creative ways to be able to get people in the hospital. This is a very, very difficult population to have show up, and it takes a lot of work, so it takes multiple phone calls, it takes a lot of encouragement. And I think the other piece that we've added this quarter is that we're doing a much better job preparing the patient who's coming into our hospital. So we're talking with them about the things that they can do while they're with us. So this population tends to be one who, when they come into our hospital, they want to continue to leave the hospital to go to external appointments. We're making sure now that people are actually taking care of those appointments before they come into the hospital, so they're less likely to leave, because we know that every time they go out for an appointment, they are at risk of relapsing and they are at risk of not coming back. So that, I think, has actually increased our admissions in addition to people actually staying in the hospital. Turquoise Lodge is fortunately a part of the Department of Health PI plan. And what we did is we identified the last 4 quarters of our accomplishments. And so our goal or our contribution is basically tracking how many days does it take to get in our priority population. And our priority population are women who are IV drug users who are pregnant, and men and women who are at risk of losing their children because of their substance abuse. And so you can see that the first quarter, it took us almost about 5 days to get these folks in. The second quarter, there wasn't that much of a difference. The third quarter is when myself and my QI director started to really look at strategic ways to get these folks in. And so we basically were doing same day appointments. And in the last quarter, we're actually pretty close to getting in 1 day, which is really significant. Our next year's quarter PDSA outcome that we're going to be looking at is actually looking at how many of these folks actually make it to our hospital and are admitted. This population tends to be one, too, that's very tricky to come in, because women who are using drugs or alcohol are at risk of CYFD involvement. There is a lot of fear and transparency around drug or alcohol use while someone is pregnant or at risk of losing their kids. And so I think we've done a really good job this year getting people into our hospital. This slide represents our monthly revenue and what we don't collect based on a couple of different factors. Uncollectible, unbillable, and charity care basically represents individuals who either don't have health insurance, they are in our hospital, but the recommended length of stay is longer than what their coverage is, and basically they're not eligible for health insurance. So we continue to collect about the same amount. This year we did make a surplus, so I'm very proud of our team. And on the bottom of this is our aim statement for our next fiscal year, because what we're really going to be taking a really close look at is our self-pay collections. That has been as low as 3%, but we are wanting to get that up pretty consistently. That is a challenge basically because when we do have people coming into our hospital, they are using drugs or alcohol. It is a very difficult decision or discussion to be able to talk about money. And so we are looking at some creative ways to have that conversation throughout the first 48 hours of care. The next slide represents our contract costs, which have been pretty steady throughout the fiscal year. I did identify at the bottom that this last quarter we were able to shave off a little bit of our contract costs with our nursing staff, and that's based on one nursing hire that we had this year. But those costs have pretty much remained the same. In our human resources department, we've actually been successful in hiring one nurse, one custodian, and 3 psych techs. What we've been trying to do is really engage more with schools, and we've actually had kind of a surge in high school students calling and being interested in our services. I think it is probably a trend because in high school now you can actually work towards having an internship in some of the interests that you have kind of going into college. And so we've had an increase in high school students calling and being interested in doing some volunteer work at our hospital. This next slide represents some things that we're trying to do to retain our staff. We, as Frances was talking about her contract with Santa Fe Mountain Center, we have the same. And in this quarter, we were really excited because we've always tried to have 100% of our social rehab staff and our patients actually go to Santa Fe and participate in their ropes course. And we haven't been able to do that because either the staff have been had to stay back because of the acuity of the patients, but we worked really, really hard for about 2 weeks and we got everybody ready, and 100% of the staff were able to attend and 100% of the patients were able to attend. And I do see this as a retention issue for my staff because I think when they are able to participate in some varied programming, it makes their life and it makes their job more interesting. We've also continued with our quarterly barbecues, and we continue to do some significant monthly birthday recognitions. This slide represents our competency blitz that we did this quarter. So in preparation of Joint Commission, what we're trying to do is basically adhere to the accreditation standards, where we have to demonstrate that nursing staff, psych techs, clinical staff, and housekeeping are all, not only are they capable of doing their jobs, but are they competent. And I don't know if you guys can see, but we engaged a patient who's a really good artist, so we did the body of the EKG guy there, which is kind of cool. It's a tattoo across his chest. So these are some pictures of my DON and a nurse tech, some nurse techs doing some competencies. We were able to do that 100% with the staff, and we accomplished that in 1 month. So at this point, all of our competencies for all of the direct care staff and the necessary disciplines have been complete in preparation for commission. This next slide represents our marketing and our outreach. So these are all the different systems that my utilization review person and my discharge planner have been outreaching to the community. So what we've been doing is we've been aggregating our data and seeing where do our patients come from and where do they go. And then we're trying to basically have a face-to-face meeting with these systems so that we can begin a collaboration and a conversation and an increased relationship. And it's been successful because I think that we are getting more referrals from that, and we are having a much smoother discharge planning process because of these new relationships. I did make a note on the bottom, which is our new AIM statement. We have been traditionally been engaging with about 6 of these outreach efforts each month or each quarter, and this next fiscal year we're actually going to shoot for 12, which would be about 4 a month. And that's the end of my presentation. Do you guys have any questions?
Thank you. A few things. One, I was wondering if there's been consideration to doing the IOP in the evenings so that those who manage to get back into employment would potentially have their employment disrupted to tenure.
There is. We are going to start off with a day track. And once we get that track up and going, we're going to move to an evening track with our clinicians. Because outpatient is a new service for AAA's Lodge, we've always done inpatient services. Individuals are pretty used to working a certain job time. And so working from 5:30 to 8 is something that I'm working towards. So we anticipate starting our first track August 21st, and then hopefully 90 days after that, and hiring 3 more clinicians. The intention is them running the evening track.
Are you able to contract with private practice providers who might be willing to work those kinds of 18 hours as a second gig? This is thought. And I was also wondering, we have a concerted push in corrections and detention centers and with first responders around naloxone distribution and have the ability to administer it appropriately. I'm wondering whether or not you're able to provide more discharges with a take-home naloxone.
We're looking at that actually in our MOTU clinic and also with the discharges from our hospital. We anticipate eventually opening up a bed management clinic that would also assist with that with our IOP patients. And so we are looking at that initiative this coming year.
Okay, you have some roadblocks there that we can help you with. Okay. And I'm wondering whether or not you're seeing fentanyl in your.
We are actually this last quarter we're seeing a lot of individuals coming in who have been using heroin that has been laced with fentanyl, and that has actually proposed a much greater acuity in our hospital because these individuals are coming in with that presentation, and then within the first 24 hours or 72 hours of admission are much sicker than we have anticipated, and so that is something that's been happening this last 90 days in a much higher rate.
If you could kind of keep me in the loop on any data reporting we have around that,
okay.
I think that would be very helpful for the whole collaborative because we talk about harm reduction strategies that has huge implications for us. And then I sent you all the draft LOB with the IMD for the MCOs. I'm wondering where that is in your own review and whether that meets your needs.
It's been reviewed, and I believe our comments have been sent back. Correct. And so we are good on our end and ready for it to be submitted.
Okay, I will let us copy that response.
Yeah, what do you But it did go back.
All right,
Yes, so we'll follow up
Thank
on it too.
Thank you.
Thank you.
There's no further questions for Turquoise Lodge. We'll go to Los Lunes Community Program with Jill Marshall.
You can stay there, Joe. If you want to stay there, I can just move again.
Come on, Bill, stay in there.
Good morning. I'm Jill Marshall with the Los Lunes Community Program. We provide a variety of services to adults with intellectual and developmental disabilities. They're all person-centered. They're all supported by interdisciplinary teams, and we promote independence. The services we provide include living supports that have supported living, crisis residential, and intensive medical living. We have customized community supports where we provide skill building, work on natural supports in the community, increasing independence, decrease the need for paid supports, strengthen interpersonal relationships, and foster personal growth in interpersonal relationships. We have community integrated employment, where we work on vocational assessments, trial work opportunities, and job coaching. We also provide services for the specialized dental clinic to individuals with intellectual and developmental disabilities, where we provide hygiene, routine dental, and specialized dental services. And then we also operate the intermediate care facility for individuals with intellectual disabilities, for those who are committed to us under a core commitment, generally the 1.6 commitment, where we provide protected residential setting, active treatment, ongoing evaluation, planning for 24 hours a day, 7 days a week supervision, and service coordination. Our average census in supported living is 58, intensive medical living 1, and 2 crisis. Currently, we have 58 individuals in customized community supports, 29 in community integrated employment. We have 1 currently in our intermediate care facility, and we have 2 referrals coming in the next 60 days. Our unduplicated total is 71, and our duplicated total is 154. It's important that we use both of those numbers because we provide different services throughout the day, and it impacts our staffing levels. We have 34 Jackson class members, and the dental clinic sees 570 patients on their caseload. Our our projected overage or shortfall was 291,691 in deficit. Our contract costs were 22,350 a month. The majority of our contract costs are for nursing. Our total costs are incomes 579,422. Our billings or patient revenue received for June 2017, 596,609, which includes the DB waiver, the ICF, and the dental. Uncompensated care, 57,150, and our collection rate is at 92%. It usually drops this time of year. That's when the majority of our budgets are submitted, and then we're able to go back and rebuild those funds within 90 days. Our overall overtime trends, we were trending down. Unfortunately, our vacancy rates are now higher. We were impacted by having to have a hiring freeze, and so our overtime rates went up. We started to trend down, and then we had the holiday. So we're working on our hiring again and filling those vacancy rates. Our planned projects for the upcoming year, our priority 1 is renovations and upgrades to cottages 3, 4, and boroughs, which is phase 1 of our proposed campus move. Those are the 3 buildings we're proposing to move into, which are state-owned, and then our priority 2 are renovations to cottages 5 and 6, which will be phase 2 of our proposed campus move. Our human resources, our total FTE is now at 302. Our total build is 261. Our vacancy rate is, for the overall facility, is 17.88%, and our direct care is up to 19%, which is the highest it's been. Our workers' compensation injuries this quarter are 4, and out of work 2. Our longest number of days out of work was 2. Reassigned, we don't have any. And our family medical leave continuous 2 and intermittent 7. Our marketing of services, we were on a self-imposed moratorium the past quarter. We've been off of the self-imposed moratorium, but due to our high vacancy rates, we'll be requesting to go back on the self-imposed moratorium for the coming quarter until we can fill those positions. Our staff were actively recruiting nursing. We've hired 2 nurses, which is great. Our certified medication aid, we continue to recruit and have started our training classes. We're attending every available job there. We're posting positions on Indeed and Craigslist. We've also we're requesting a rapid hire event. We've done interviews the past 3 days as well. We're hoping to pick up staff. We continue to work with Discovery We're working towards our team having a better understanding of the wants, needs, strengths, and preferences of the people we serve, developing services and supports, and helping the individuals to seek and become employed if they desire to do so, and to also educate the teams on informed choice for employment. Our licensure and accreditation, we continue to operate in full compliance with all conditions of participation for the ICF and the waiver services currently. And our other initiatives, we continue to have town hall meetings. We have a monthly brown bag with leadership. We have team building. We now have a communication committee, which is directly working into our quality assurance initiative, and it's becoming our voice of the customer. So we can incorporate from all levels of the organization, the people we serve, and guardians into our quality assurance initiatives. We have one-on-ones with the administrator where any staff or guardians, if they'd like to meet with me, we're having regular meetings and visits at different hours and on different shifts. We have the Extra Mile Employee Appreciation Awards. We have our upcoming Employee Appreciation Barbecue next Friday. And we have on-the-job training manuals so staff can reference those. Are there any questions?
Questions on this? Thank you, Jill. We'll go to the next reevaluation. Welcome to
Thank you.
first governing board meeting, of course, as our new administrator for the New Mexico Rehabilitation Center.
We started.
Well, good morning, everybody, and again, thank you everybody for a warm welcome back. It's a lot of familiar faces, a lot of new faces, obviously, but I'm happy to be next to you guys again. It feels like I never left. It's a short time, but just to get started, New Mexico Rehab. So we continuously try to we're making improvements on our 3 service lines, the rehab center, our medical rehab unit. We continue our outreach to our main referral bases, such as UNM, UMC, and our 2 local hospitals, Eastern and Loveland, as well as Artesia and Carlsbad. But we're trying to develop a better relationship with them, trying to re-educate them about the type of patients we do admit into our program, that acuity, to meet independent rehab, medical rehab admissions. We've been in discussions with UNM telehealth program. We are looking into possibly having them extend services, telehealth services in the neurology, neurosurgery, orthopedics, and maybe psychiatry in the future to our MRU program. This will help our physician currently make decisions in appropriateness for admissions, especially how they're comfortable in the decision making of how we treat those types of patients with traumatic brain injuries, spinal cord injuries, that more complex decision making that has to be made. We currently we're servicing most of Chaps County. We still service the Betty County, Bay County, Roosevelt County counties. Average length of stay within that program is still ranging from 2 to 4 weeks. Our IOP program, we have 2 classes going on right now, 2 sessions a day and an evening track. We're currently looking at expanding into a group 3 track, which is possibly the early morning from 7 a.m. to 9:30 a.m. We've had great success in the 2 classes so far. We've been able to sustain 30 to 31 active patients in our IOP program. Based on the program needs for 2 different classes, we have to max out 50. That's our cap through the program that allows for the patients. So we want to extend. The need is there. It's within the community. I think offering that 3rd group will help the community help reach those patients who maybe want to get the IOP early before the start of their day to forward. So our referral base still continues to be strongly with probation parole officers, DUI programs. They hold meetings with them. In fact, on Monday, we are meeting with our local judge to start looking into other accommodations we can help them when we start on another third track. Medical detox is up and running since we started in May. We've dedicated 8 beds for that unit on CDU. There's 20 social rehab aides, medical detox. Still, the average length of stay is from about 3 to 7 days. We are a 24/7 patient care facility, so again, some of the challenges they're finding the nursing staff, the techs, but we continuously try to make efforts to with the local nurses to try to recruit and hire into those positions. Our medical detox referral base again is strongly with our probation parole officers, which we continue to have. Well, I'm just so total for the past 3 quarters, our MRU census has been on average 27, 26 for this quarter. Total client days 490. We've admitted 68 total med detox patients, 38 this quarter. Our recidivism rates is only about 40%. We are one of 2 sites within our local community who are offering a safe hospital setting type of detox. So, patients, as far as choice of detox, are us or the local hospital. Therapy continues to be even based on our census that we have for MRU. They continuously provide 3 hours of therapy 5 days a week, 15 hours on each patient. IOP is census still 52 individuals. So far, we've admitted about 138 individuals into our IOP program. We're averaging there in 30 to 31 active patients through the program. This past Tuesday, we had a max of 14 patients in our day class and 8 in our evening. Although our census there with the 2 groups seems to be in the double digits consistently, which is great. Great support from our counseling staff, as well as Lisa Luman helping us refine that program to get it up to par with it needs to be. The staff of the Bayard, Adina, Pam, Steph, and I've been helping the program be successful. So our accounts receivable side, last quarter, looks like we had for the total monthly revenue collected, now that we started med detox, ILPs running up in grade, we've actually got about $44,000. We hope this continues to climb. We project it will be climbing here in the future as restarts, enhancing our front end services and intakes, such as Shauna spoke earlier in her presentation on the call intake process and looking how we can collect those upfront costs. Really notify the insurance, getting the prior authorizations, the collections, making the payment arrangements with the patients, which hopefully we can see a bit of an increase more in our revenue. Then our uncollected reports going after those payers, ensuring that we're getting paid for the services that we're rendering, following up with them consistently. So that's looking good there for this quarter. Our contract costs for this quarter, we're actually decreased it down from about $65,000. Last quarter was about $175,000. Shirley Donaldson, our finance officer down at our facility, has done a great job in reviewing the contracts and renewing those in the last quarter. Kudos to her. We continue to, with our projects coming up in the future, to our top project, $250,000. And our swipe block system as well as the camera system. The swipe system hasn't been updated, or camera system, since 2009. The company that does our batch swipe has left. The camera system just needs a total upgrade. But That's our future projects for this fiscal year. We are Joint Commission accredited. We are in our Joint Commission window. We submitted our application in February. Our due date for survey is February of 2018. On our operating license side, issued as the new administrator, we made the operating license reflect the type of services we're going to plan to render in the future, which is 43 hospital beds and split into 15 functional MRU beds, the dedicated 8 CCU beds, and the 20 social rehab beds. On our human resources side, we have a total of 93 FTEs currently with 30 vacancies. Our average quarter vacancy rate is about 28%. Our focus areas for hiring the key positions are our position for our CQ and MRU side. That's that second position, and again, there's some of those nursing vacancies in those key areas, such as our GON, staff development nurse, nurse shift supervisors. So the total of 8 nursing vacancies. We are meeting with our local university tomorrow morning, Eastern New Mexico, University of Roswell, with Diane Ellington, who's the health science director down at the university. We're going to discuss the job postings we have, the description of qualifications into those areas, and where they can post them up for us. Not only that, we're going to look into giving a presentation, a little short brief of the type of services we offer, the job postings we have available, so that way maybe we can try to recruit some of our local nurses into our areas at the NMDOH. In this July, I know it's not on this report, but we did hire 2 nurses, a basic nurse and a supervisor nurse. Those still continue to be our priority. Our marketing, again, neurology, that telemedicine, that'll help us strategically increase our census on our MRU side with that type of population. Mexico Highlands University, want to hold an agreement with them, of course, with our clinical social workers, the type of population we get with substance abuse. And talking with Highlands, they do want to hold a supervisor and a field practicum to our hospital if they recognize that it's an actual clinical side for medical and so we're going to do some outreach there. Dr. Bob Phillips is currently in contact with us and is really circulating a few counselors through the program. The Health Solutions Committee there in Roswell. This is important as the local hospitals, Loveless and Eastern New Mexico, we come together to discuss the challenges within our community, the delivery of the health care. It's a good chance to promote ourselves. That's where we have this, see those other facilities. Hey, these are our branded service lines that we offer, intense medical rehab as well as the substance abuse. A lot of great feedback from them. Hopefully we can collaborate and join a better relationship with our hospitals for stronger referral base, as well as defining our separate service lines in the community. Outreach to our local hospitals, Carlsbad, Artesia, Eastern will continue. IOP, that's again our referral base, keeping up with that with our local probation parole departments. Focus. So performance data, we had a quality focus review, sort of a brief joint commission survey about the second day that I was at NMRC. Thank you guys. It went really well. Again, part of the review is really to focus on the type of services we deliver and around the patient, the quality of care that we give to patients. So, that monitors our processes and policies, the way we function. They did identify areas for improvements within our assessments, our treatment plans, the competencies, workflow processes, which we're very diligently working on to refine before we actually get our survey, which is again due on February 18th. Contracts, Again, we're looking at nursing contracts, agency contracts, and strategically scheduling the admissions and the way we offer care for our patients with the contracts with the nurses there. Infection controls high on our list as far as PI, narcotics, hospital acquired infection rates, and the type of population we serve, those rehab patients. To ensure that they're not when they're discharged, they're free of any type of infection. We do have, again, another PI projects environment, payments, complaints, med errors on our pharmacy side. Making sure, again, all our staff, clinical direct patient care staff, are CPR certified to handle the emergencies for patients that we've met on the high acuity side. There's we enhanced with detox. CMS on our survey side, they instructed us to do a survey, a pilot study for April and May. They asked us to send out to get patients' input on our satisfaction. We rank at 96%, which is huge for us. When we look at our uniform data system reports with our, in respect to our MRU side, we noticed that the patients that we admit on functional status, we've actually improved them up to 27%, which is well above the national, the regional and the national marks. So it compares us against 922 independent rehab facilities. So I thought that was great. It aligns perfect with our patient satisfaction rate right there. So we're not only are we providing that, but most quality care for them, they're also satisfied with the facility. Safety quality reports is 38 falls with our type of population that we get, those ortho impairments, rehab patients. They're higher risk for falls. We still continuously try to identify areas in which they're more prone to happen, or likely to occur, making sure we have that one-on-one staff with those patients there, the evaluations for falls early in their care as well as continuously. So we continuously make efforts and improvements in that area. We've had no falls with injuries. That's where our AMAs still continue, and that's due to our medical detox patients who come in for the 2 or 3 days or they want to leave quickly out of our programs. Employee injuries to errors at 2 facility equipment issues about 2. To the other issues, quality reports are usually about doors unlocked, things like that in areas where the patient falls. But those are our loading improvements, which are easily corrected. Our needs and challenges, like I discussed, our nurses' vacancies, they still continue to be our priority for hiring and filling those positions that are NMRC impacts the delivery of care. And as we increase census, again, we've got to be mindful of that strategic in place, make sure we have those positions there on that. With the acuity and the level of care we offer. Physician vacancy. Licensed behavioral health supervisors that vacancy we are currently looking at for Here's a challenge for us within NMRC. Again, based off of the 922 facilities that we were compared with, we actually accept more non-funded patients than the regional and national. And we're at 45%, regional at 15, nationals at 20%. It does meet our mission and our purpose for the patients to make sure they're getting the type of care that they need when they need it. A safety net facility, we still continue to offer these patients that we get referrals from that you don't see, regardless of payer source into our facility. So some success stories that we've had, we're currently working with Churchway's Law, our sister hospitals, that are revamping our call intake and our access. So again, increasing that patient access, increasing the time when they call, the time to actually get to an appointment into our facility. As Sean has spoke earlier, we want to make it seamless, one, make it efficient, so that patients getting time to services needed to our facility as fast as possible. We've been able to enhance that, adopt it, and we continuously still try to obtain develop a process around our insurance eligibility and prior authorization, so that way we can obtain that upfront promise. Our ROP program, that's again, it's up and running. It's been successful. We've been filling our spots, our 15 patient availability beds or spots we've been able to fill, so we're going to look at that there too. We've adopted the IDDT, an evidence-based model, into our IOP program. This will help as we move from our bed detox down to the lower level of care, which is still we have an outpatient rehab. So this type of model will follow that whole continuum of care. We are working to develop our clinical forms that way we capture the proper diagnosis, the proper treatment for the patient, and then again making sure we get that regulatory standard. We'll coordinate again with our parole probation officer support system, DUI programs, to let them know that hey, we're out here. This is the service we are providing. We're here to help. Just some positive facts. MRU, or going back to our medical rehab unit, we actually serviced more stroke patients and ortho impairments the past year. This is in comparison to our regional and national facilities, based on 922 facilities, which is really great. But you know, another indicator of the type of problems that may exist in New Mexico, we have a higher obesity, higher diabetic rate than other facilities where they're placed. So, but I thought that was great. You know, that again, matching that up to our 20% overall improvement in our functional status for patients. It's great to know that those stroke patients are actually increase their functional levels higher than the national standards. That's all I have. Is there any questions? Yes, sir.
Not so much a question as a couple of comments. One, I hear that there are recruitment hiring struggles in all facilities. And if you are aware that our New Mexico Behavioral Health Network of Care has a job bank on it, where you can post any of your behavioral health vacancies. And behavioral health professionals around the state check that site if they're searching for positions, etc. So if you're not listing your position openings, I strongly recommend doing that.
What's the name, Wayne, again?
The New Mexico Behavioral Health Network of Care.
Mexico Behavioral Health Network of Care.
Right, if you just Google that, it'll take you right to the site. In addition to that, there's also a resource directory on that site for behavioral health. And I don't know if all of your programs and services related to behavioral health are voted on that site, and our New Mexico Crisis and Access Line uses that resource directory when they get calls, and they're, getting over, 30,000 calls now. So there's high volume, and they are referring your facilities if you're not listed in the directory. And the directory is allows you as an individual facility to enter your services, your hours, contacts, etc., edit them as you deem appropriate. Within 24 hours, our vendor behind this trilogy contacts your facility and asks, somebody just came in, was changing your information, was that person authorized to do that? Is what they changed valid? And then it's a go until the next time you go in. So those are two things that I think would be resources to you. And in addition to that, given that you had some significant expansion of substance use disorder treatment, I don't know if you developed a 1 or 2 page delineation of these new services, because I think at least on the behavioral health provider side, they really aren't aware of those developments. I was even thinking when perhaps at a future behavioral health collaborative meeting, having you guys present on what you're doing in this area is developing new services to meet unmet need. We have, HHS, IG coming in the fall to review behavioral health access. And I think this could be another demonstration of what we're doing to respond to the needs statewide.
Thank you, ladies. I'm gonna ask Bill to follow up in terms of the place to post the job posting site, and also to make sure that our facilities are listed as resources, and we can have the course to present to the behavioral.
And if anybody who goes on is challenged in being able to do that, we would be glad to arrange for a demonstration and walk you through how to do that with our vendors. So if you struggle with that, let us know.
And Wayne, one of the things that I've been trying to develop is sort of on a either a rotating basis, having one of the members of the facilities come and present at the behavioral collaborative as well, even if it becomes an NMDOH facility update. And then, I know Shauna and Dr. Mirren presented, and I think that we received a lot of good feedback as a result of that, but I want to replicate that going forward. So I think it's an important connection to have.
Thank you.
Thank you.
And I think life also on some level becomes a good coordination for us too, that I don't think we've done a good job of connecting.
And especially given their unique role in the state with regards to human trafficking.
Yeah. And just for everyone's knowledge, we did start about 10 minutes late. I still would like to, move informatively, but as quickly as possible because we are still running behind. So our last facility to present will be the Fort Hood Medical Center in Todd.
5 minutes?
Ready, steady, go.
I can do this.
No, but if you haven't made, changes in the service line, that kind of stuff, that could be a quicker summary. We don't have too many new folks at the table and on the phone, so I think that would be okay to move more quickly to that step.
Do that. These first of all, Fort Barrett Medical Center, we are a 200-bed certified facility. Our services include our skilled rehabilitation, our extended care or long-term care, and our veterans unit. As was noted in the last quarter, we did discontinue our chemical dependency unit and move those services to Roswell. Our skilled nursing unit is a 70-bed unit. 10 of those are short-term rehab type beds on an average basis, along with 60 of a high and low complexity long-term care patients. And that is the unit that offers the therapies, physical, occupational, and speech therapy. Our extended care unit consists of 90 beds. We have a 24-bed unit for males, one for females is 24 beds, and then 42 bed of high-low complexity long-term care. And then it also covers our dementia care beds as well. Our veterans unit is 40 beds, all male, both high and low complexity, and both short and long-term care. This past month, I was going to say quarter, but it's actually been the past month, we were very busy with our licensing and certification. Our CMS survey was held from the 12th to the 20th of June. Our Veterans Administration was the 27th and 28th of June. State Board of Nursing also visited us on the 27th to review our certified medication assistant program. And we had external auditors in on the 28th to review our inventory.
I'm tired just hearing about it.
Our Veterans Administration survey was our recertification survey. Very few recommendations. There were no serious items cited. We are still waiting on the official report from them. Our Board of Nursing, again, was to renew our CMA training program. There were a couple needed paperwork items that we were able to do right there on site during their visit. And we expect renewal on that program as well. External auditors, it was an inventory audit, as I mentioned. We're still waiting on any official reports. There were no significant issues. There was some mention of having trouble in being able to print a perpetual pharmacy inventory report, but I think we have figured that out and resolved that, so that shouldn't be a problem either. Our CMS annual survey, a little bit more, I'll use the word exciting. It was for our annual recertification as long as it was bundled with a complaint. It resulted in 8 tags being cited. 4 of those tags were related to investigating and reporting injury of unknown origin. Those were all due to a complaint. We had 1 tag related to documentation regarding follow-up on complaints recommendations received during our resident council. 1 tag related to updating care plans when care needs change. That was more specifically in regards to if someone's put on isolation. Also another tag regarding efficient number of nursing staff. 1 tag regarding infection control practices and policies and procedures. Our utilization, in the 4th quarter, our patient days dropped, as you can see there. Our average daily census also dropped in the 4th quarter. Our average daily census averaged right around 133, thereabouts, for the quarter. Our occupancy, running around 93%. Our admissions and discharges, the 4th quarter, you can see there was a lot more admissions and discharges than what we had experienced in the previous quarters, but they're for shorter periods of time. That's why our average daily census dropped. Finances there, as you can see, sorry, that's not bigger. On the left side of the graph with our revenues, expenses, and our uncompensated care. It indicates there if we were paid for everything we provided, we'd be at break even most of the time. Our collections have been good in the 4th quarter, with being our strongest quarter in collections. Of course, that was after a slower 3rd quarter in collections. Our collections for the 4th quarter are just under 121%, and our collections year to date just under 97%. Human resources, our total staff FTEs are at 260, with direct care vacancies, 33.5 or 20.63%, indirect at 23.5 at 15.21, with our total vacancy being 57 or just under 18%. On the clinical side, our care hours, our actual PPDs are 3.62. Our target is 3.75. Under infection control, we had a total of 74 infections, which is 6 per 1,000 patient days. The HIE infection rate is 56.49%, and we had 9 multi-resistant organisms in our building for the quarter. Some of our training initiatives, we're in the process of completing our annual safety refresher that we do every year. Also, we're training on clinical competencies or testing on those with our certified nursing assistants, focusing on the pericare and assisted transfers. Our infection control program, that is under total review and revision. And our quality assurance performance improvement program, instigating our new abacus along with some other initiatives. And I think that's it. How's that? Any questions?
Anybody have any questions or thoughts? Yes, Eric?
The job testing, I know you got a ton of questions about it the other day. I did too at LHHS. Is there any chance, or is there anything that we can do for that community down there? Is there anything that we're doing right now for the community, kind of backfill the services?
So, so can you explain, when you say backfill those services, are you saying create the same kind of services that Yucca Lodge had performed, that we transferred, that are now being performed at Roswell?
I'm not really sure. I was kind of asking you, are you guys doing anything, or is there anything that you can?
So the plan becomes the expansion of the beds at Fort Bayard to serve veterans in its intended purpose, but also to work with outreach communities to ensure that that community understands that the services are being provided better in Roswell and that they are encouraged to send them there. CASA is also building its own facility and they should be challenged with taking on some services as well if that's the way that they feel with their business model. But we have two really great programs in New Mexico that the state operates where those services are available, and that's Choice Lodge and NMRC. And so really that community is served just like Sandoval County is served, just like Guadalupe County is served, just like Sierra County is served, just like Doña Ana County is served by sending, if they want to go to a state system. Does that make sense?
It does. I feel like some of the members down in that area are kind of dissatisfied with that answer.
Yeah, so I've had some conversations with since then or simultaneous with that hearing happening about that same thing. And I completely and 100% understand the legislators wanting to support its district and enhance services in its own district. I really get that as a legislative perspective, but then every single legislator would want its own individualized set of those programs in their own county. And then that becomes the challenge, but I've spoken with Representative Dow, I've spoken with Senator Morales on a number of occasions, and really enhancing services to veterans and then making the link between what services are available at Turquoise Lodge and at NMRC becomes how we support that, because we're committed to outreach in other parts of the state to ensure that people are getting the services they need. So I'm really not comfortable as a state agency giving favoritism over one district over another. That's kind of what I've said to others, and that's what I would say here.
I think the things we can do to support the community directly is to make sure that NMRC and Turquoise Lodge have some directed outreach efforts in those areas so that they're aware that the services have been transferred and where they can get services, and making sure that the existing services in those counties, like TUCASA, Since and the other IOP services that are being offered there, are perhaps part of the resource guide that Wade was talking about. And I think that's two ways we can directly support them as opposed to starting some new services.
But also expanding the services to veterans at Turquoise Lodge becomes one of the things that will also help that district. I know one of the concerns is also from their mind, the loss of staff. So there were 5 people or 6 people or however many people that were serving at the lodge at any given time. And now those individuals are no longer there right now. And so the quicker that we can work to enhance services and enhance our ability to serve veterans better, I think that will also help in that area. So that's what I would say, and it's not probably the exact answer that you're looking for, but nor is the state obligating to provide services that weren't being provided as well as they can be provided at NMRC.
I mean, I think everybody gets you guys managing resources. Definitely decisions. So then the only other thing was I guess we kind of need capital outlay funding to ramp up those services for the veterans there. Is there a chance of getting that to the operating budget?
So I'm looking at all the budget numbers, I'm looking at what we can do, and there'll be more to come on that. I'm looking at that. I'm not, I don't have an answer to that right now.
Are there any other questions for Barry? Seeing none, I get a motion to collectively accept all of the governing body reports. Do you have a second? Come on, okay. And now we'll go to our program area 6 financial report. Lloyd?
Good afternoon now. We're running a little bit behind. So let me wait until the slides go.
You didn't receive your stats.
Okay, so first slide should show, or first document should show the deficit actuals for the last 3 fiscal years. As you'll see, in the last 2 fiscal years, we've made significant improvements in reducing our deficit. Yeah, the second slide just is a detail, a little more detailed layout of fiscal year 17. 18 OPUD includes, or actually doesn't include, state veterans home, so you see a significant change in the overall total budget for facility management. And then this is a breakdown of each facility and the Office of Facility Management, as far as how budgets are allocated for each. And then the vacancy rate for direct care positions, our goal, obviously, is lower goal than our actual. Still at 26% for direct care positions. Third-party revenue collection has improved considerably, which has a direct impact on the deficit reduction overall. So for all facilities, thank you for the work you've done to collect revenue. It certainly helps. The number of major injury falls per 1,000 patient days. Our goal is 3. We're at 10th of that, so that's a really good number. That's all I have. Questions?
Okay, seeing none, we'll go to approval of policies. Dr. Collins. Essentially, Dr. Collins was asked to do the prevention piece, not necessarily the policy piece, but everyone has reviewed the policies. So.
We have a motion to approve the policies.
Second. You're gonna actually needed a motion to approve Roy's financial report. So moved. Second. Go for your credentialing report, Dr. Collins. Thank you.
Thank you. For credentialing, we have Sport Mayor Heather Schmidt, the one that Los Lunas at NMDOH, Bruce Anderson, Lee Archuleta, Mary Bunker, Ruth Flores, Susan Gerber, James Zava, Chelsea Lucero, Barry Weinstein, Nanette Roswell, Public Health, Natalie Krasner, Christopher Novak, Steve Romero, Ronald Romero, Sequoia, Dr. Sorry, I won't try to pronounce his first name, William Needorf, and Turquoise, Dr. Ansari. All these providers are recommended for initial or reappointment credentialing and or privileges. Do we have a motion to approve?
So moved.
Do you have a second?
Second. Next on the agenda is announcements. The next meeting, of course, will be Thursday, October 19th at 10 o'clock in the morning, and we'll give you information about the location and the time. Unless there's someone who's dying to host us and you want to raise your hand, I can probably do it. I try to make sure. Maybe it's a way to take it. Are there any other comments from the public? Is there anyone on the phone that may? Okay, no. We do have some old business listed. I'm going to move through this quickly, and I'll on A, and then I'll defer B to later to our next meeting. It's nothing that's urgent, but just in the interest of time. So on the bylaws review, I just wanted to mention that we had included language last time we looked at the governing body bylaws with regard to the state veterans home in the event that the legislation did pass. So technically they don't have to be changed. because it was including them as a member unless or until they went under the Veterans Department. However, I will reach out to Mitchell Lawrence and see if there's any interest in them, like I said, continuing at least as an ex officio member, so they can stay connected with us and get some of the information about what's happening and some of the ideas. See if that's something they'd like to do, or if they want to have that connection in a different way. But that might be an amendment to the bylaws. The other amendment to the bylaws that I would hope we would entertain is adding Susie Archuleta, or not necessarily by name, but by title. She's the long-term care administrator at New Mexico Behavioral Health Institute. And although, of course, NMDOH is represented here by their administrator, we thought it might be, or Bill thought especially it might be important for Susie to be part of the discussion here, because she is, of course, responsible to have her own independent licensure and has some responsibilities for that long-term care in a different way. So we thought that a different way than the other divisions at NMDOH. So we'll probably add her as a member to the bylaws as well, or something that will also continues. So those are the only things that will be changed with the bylaws. The other thing listed was just the facility administrative job descriptions. I will defer that discussion to later, but again, we mentioned it last time. It's important for the governing body to have some input into the people that are brought into the administrator positions, especially for those who are Joint Commission accredited. So we want to have a meaningful way for the governing body to comment on the questions that are asked, or the job descriptions, so that way you have a voice in that process. That's all we have on the agenda. Of course, we'll adjourn at this point to our executive session, excusing the public. Will not take a vote on anything. Okay, so we're back on, we're adjourned the executive session, we opened our public session. We did not take a vote on anything in our closed executive session that would have needed to be heard by the full board and the public. I would just like to entertain a motion for adjournment of the Stone Board.
Make a motion.
Second? Second. Thank you guys for coming.
Thank you.
Okay, so we have, about